Carle combines clinical care, health insurance, and research in a way that solves problems today with an eye toward the future. Supported by a deep philanthropic spirit and dedicated to making life better for as many as possible.
Meeting the ever-changing healthcare needs of our communities, Paris Community Hospital Family Medical Center is now Horizon Health, with the same ownership, management, providers, and employees. Horizon Health provides patient care and promotes wellness to the communities of East Central Illinois.
At HS St. Anthony's Memorial Hospital, we are at work transforming heart care, rebuilding knees and hips, delivering new generations, and focused on providing health care to you. We are HSHS St. Anthony's Memorial Hospital.
Sarah Bush Lincoln Health System, supporting healthy lifestyles, eating a heart-healthy diet, staying active, managing stress, and regular checkups are ways of reducing your health risks. Proper health is important to all at Sarah Bush Lincoln Health System.
Hi, I'm Key-Ann Armstrong. I'm your host for Being Well, and today we are going to be covering the topic of lung cancer. And I'm joined here with Dr. Jagarlamudi, and you are a hematologist and an oncologist with Sarah Bush Lincoln, is that correct?
Yes.
Yeah, well, thank you so much for coming today.
Thanks for having me here.
Yeah, so tell me a little bit about yourself and what you do. What is a hematologist and an oncologist?
Well, hematologist has to do with blood problems, and oncology has to do with deal with cancer. Okay. So it's a dual specialty, and we're one of the professions where we have that. We're able to have dual specialties. Okay. And so I originally came from New York City, Brooklyn. Moved into Champaign and commute to Mattoon. Worked with Sarah Bush for the last 5.5 years.
Okay.
And it's been a great community. Everybody's been friendly, and we're happy to be here.
Yeah, well, I'm happy to have you here today. This is something that I think affects a lot of people's lives, and we're going to be talking about that today. So how common is lung cancer?
It's the second most common malignancy in the United States. As per the Sears data, you have about 234,000 new cases of lung cancer estimated for the year 2018.
Oh my goodness.
And it's second to breast cancer. But it is the most leading cause of mortality in the United States. About 154,000 deaths as per the Sears data estimated for the year 2018.
Wow.
So I mean,
those are high numbers.
Those are high numbers. Yeah, it's a bad disease to have, with a lot of new hope actually. And it usually affects people in the age of 70, the median age. The average age is about 70. Affects males more than females.
Really?
The highest subpopulation is ethnically and gender-wise, the African American males are the highest incidence of lung cancer.
Really?
Yes.
So what do you think contributes to those high numbers in those populations that you just mentioned?
The main risk factor for lung cancer is smoking.
Okay.
Right? And smoking, there was a large study by the American Cancer Society where they noticed that when they compared with non-smokers to smokers, they have a 20-fold increase in lung cancer. And when you compare it to one of the other causes, which is occupational exposure, for example, if you take asbestosis exposure, even if you take the worst exposure, it's only a 5-fold increase. Now with smoking, we deal with 20-fold increase of lung cancer. My
goodness.
And I get a lot of questions regarding smoking. And hey, a lot of my patients ask me, hey, if I stop smoking, my risk goes back to normal? No, it doesn't. It doesn't go back to as much as a non-smoker. But it usually gets back to less than half the percentage. Okay. So if you have a 20-fold increase, 10-fold would be half, and less than 10 would be the times the risk you would have lung cancer. But as you are abstinent, the longer, the lower your risk becomes, but you'll never get back to a non-smoker's risk.
Really?
Yes.
Okay, and speaking of non-smokers, let's talk about secondhand smoke. How prevalent is that versus a smoker?
When you compare it to a non-smoker, it does go up 20 to 30%.
Yes.
If you compare it to the same ratio, when same comparison, the smokers become 2,000%.
Okay.
So it's significantly more. So passive smoking is a risk factor for lung cancer.
Yeah, absolutely. You know, there's different, I guess, ways of smoking these days with the vaping and, you know, all the different things out there. Is there a difference, vaping versus cigarettes, pipes, cigars, different things like that?
Yes, the vaping, I mean, there's no data out there yet. You know, it hasn't matured, I guess, to find out the long-term effects of it. But cigars, yeah, they have a higher risk.
Okay.
All the other tobacco, nicotine, I mean, the chewing tobacco, all these have high risks of lung cancer. But the vaping, it's not there yet, the data to kind of tell how much is it going to impact, so for us to make a recommendation. But you got to assume a lot of chemicals in there.
Yes.
We'll probably eventually will know in the future.
Yeah, we'll be hearing about that at another time.
Yes.
So how do you detect whether a person has lung cancer? What happens?
So usually detection-wise, there are a couple of ways. You know, there's screening methods now we can do that's like similar to mammograms and pap smears. Now we have guidelines for screening for lung cancer.
Okay.
Before, the data was not there to support x-rays, annual x-rays, instead of standard care where somebody comes in with a cough, shortness of breath. Usually you treat them for the infection, and then you get an x-ray and you find something and you go after that spot. But if you do an annual x-ray, it didn't show any benefit. Recently, the National Lung Screening Trial data was published that there is actually a 20% reduction in mortality related to lung cancer if you do a low-dose spiral CT scan. So they compared 50,000 people with an X-ray and a low-dose CAT scan.
Okay.
And they noticed when it matured, there was a 20% reduction in mortality because of the low-dose CAT scan, CT scan.
Huh.
But it comes with a downside. So, you know, 4% of the nodules, only 4% of those nodules that they found were malignant. So it has a high false positive rate.
Okay.
Okay. And, you know, and 24% of the people they did find the nodules, they had aggressive procedures, meaning like a mediastinoscopy where they go into the chest, they have a lung nodule, lung biopsy, a thoracoscopy where they cut in and take it with the camera, go in with the camera into the lung to get a biopsy. So these are invasive procedures. In that 24%, those 24% were benign. So they had to undergo those procedures for a benign nodule.
Okay.
So
this is less invasive.
Yes, yeah. This is the CAT scan led to those procedures.
Right. Oh.
So there's a downside to the screening.
Okay.
So how do we kind of battle that and take that to our advantage? So you basically, as per the NCCN guidelines, you have to screen high-risk patients.
Right.
So the high-risk patients are basically between 50 to 74 years of age who had basically a more than 30-pack year history of smoking. That's 1 pack per day for 30 years or more.
Goodness.
And haven't stopped. I mean, even if they stopped, smoking cessation should have been less than 15 years. These two combined will put you at a high risk category. So then you will be eligible for the screening.
Okay.
So, and then we don't know the data yet. How often do we screen once we start? So these are all yet to mature, so we don't have that information. But yeah, this is a way we can screen for lung cancer and catch them very early.
Okay. So let's talk about that. When you catch it and it's detected, then what happens? Are there tests that happen at that point?
Yes. Typically when you're diagnosed with a nodule, you get a biopsy, it comes back positive. You have to know where exactly it's gone. So how much is it spread? Basically, that's the clinical stage.
All right.
The clinical stage gives us an idea where to go next. What is it, a surgical procedure that we need to cure the disease, or is it chemotherapy with radiation? So staging works. Staging is made up of getting a PET scan, a whole body imaging to see if the disease is anywhere else.
All right.
Because lung cancer is usually spread to the brain, to the bones, to the adrenal glands, These are the common areas that it goes to. So we have to get imaging to rule out metastatic disease.
Yeah.
Usually in the brain, you do get headaches, nausea, vomiting. These are the symptoms that they come up. Sometimes it's more symptom driven also, but we do the standard workup.
So is there a reason why it spreads to those particular areas of the body?
The lung cancer is hematogous spread, basically through the blood, and that's usually their scenario. That is their route when they go through the blood, and usually it goes to that route, to those areas.
All right. So is there
and one more thing I wanted to add is it goes also to the lymph nodes, to the locally, because the lymph nodes where the lung drains into the lymph nodes in the center of the chest, that's the other areas it goes to.
Okay. So is there just one type of lung cancer? Are there various types?
Basically, lung cancer is broadly initial division is basically you have non-small cell lung cancer and small cell lung cancer. They're treated differently because they're different cancers. The small cell is a more aggressive cancer. It's highly associated with smoking, and these lesions are more peripheral, meaning they're on the not in the center of the chest, but on the outer edges of the chest. And I'm sorry, let me take that back. The small cell is in the center of the chest.
All right.
The other cancers are on the more peripheral side. So they're very aggressive tumors, the small cells. They multiply very fast. You have to be aggressive. We treat them like an emergency.
Okay.
We get them on board with all the workup and
Quickly.
treatment within a week to 2 weeks. We're pretty fast in trying to get the treatment as soon as possible because they do multiply pretty fast. The non-small cell are further classified as squamous cell, adenocarcinoma, and large cell, and then you have neuroendocrine carcinoids, low-grade neuroendocrine tumors that are also seen in the other types of lung cancers.
All right.
Why do we need to know what type they are? Sometimes the treatments vary. Certain chemotherapies work well with squamous cell, certain with adenocarcinomas. And certain types of cancers exhibit certain mutations, genetic mutations that are eligible for targeted therapies, which are the newer things that are available out there. Apart from chemotherapy.
Okay, that's what I was going to ask you. I was wondering if that was different from chemotherapy. Let's talk about that a little bit. Like, what are these therapies exactly?
So nowadays, when we have stage 4, that means distant spread, not confined to the lung. We normally do a routine evaluation for mutations in the tumor. So nowadays, we've found out a certain number of common mutations that actually drive the cancer.
Oh, really?
Yes, and the common ones are the EGFR mutation. Then you have the ALK, ROS, BRAF mutations, MET. So these are all terms that we check. These mutations we check with next generation sequencing, and we use basically this. One of the testing that we do is called foundation medicine. There's Caris Life Science. These are the two common studies available out there that do this gene sequencing and then give us these alterations in these genes. So once we get these results come back positive, so EGFR is usually prevalent in about 10 to 15% of the American population, the Caucasian American population. The Asian population, it's more prevalent, about 35%, and is usually more seen in non-smokers. In that group, it's a higher prevalence rate. So once we get these mutations, they're targeted therapies. Basically, one of them is called erlotinib, which is a targeted therapy that blocks the effects of these activations. So these mutations actually activate the cell pathways for the cells to grow, and this pills block those effects, and thereby controlling the cancer without using chemotherapy. And when they did studies with these targeted agents with chemotherapy, they did fairly well. with response rates compared to chemotherapy. So if we find these targeted agents, then we don't go with chemo as the first route for stage 4 lung cancer. We go with the targeted therapies.
All right. And when you mention stage 4, does it go 1 through 4? Is 4 the highest?
Yes, 4
Okay.
is the highest.
All
So
right.
usually you have stage 1, which is limited to the lung. If you look at the composition, how they're diagnosed, majority of the time it's diagnosed at metastatic when it's spread beyond the confines of the lung. And that's usually about 55-56% of the time. That's how it's diagnosed.
All right.
The localized is when it's limited to the lung, where they can curatively resect the tumor, is usually about 16% of so with the screening, we're hoping we find more in the earlier stage.
Yeah, absolutely.
And we have a better chance at curing the disease.
That's what I was wondering, is it curable, is it treatable? So it just varies, I guess.
Yes, it varies on the stage. So if you're doing stage 1, if you come to when you're dealing with stage 1, surgical resection is curative. Certain indications that we need to give treatment afterwards for sometimes the size of the tumor, sometimes the tumor is present at where they cut the margin. So there are additional treatments that we can give, chemo and radiation. That all depends on what we find in the final pathology, which is when they take the tumor out. That what tells us the pathological stage. That's what guides us on if they need further treatment, and also gives us the prognosis and of the disease.
All right.
As per the stage.
Wow. Are there side effects to any of these treatments? And if so, what are they?
Yes, I mean, it depends. Again, what we decide to go with. We have actionable mutations, then these pills have their own side effects. Some of them have diarrhea, you get a rash, you get fatigue, tiredness, it can affect the blood counts. So these are the targeted therapies. And how do we manage that? Basically, we withhold treatment or reduce the dose of the treatment, and that's how, and we reinitiate at a reduced dose and we watch again.
Yeah. So how does a person get to you? Are they referred? Do they go directly to the cancer center? I mean, what's the process? If somebody is feeling like there might be an issue, that I don't know what the symptoms are, maybe we should talk about that too. And when do you go see a physician?
So usually the symptoms for lung cancer, usually the most common ones are the cough. You're going to get cough, shortness of breath, and chest pain. Sometimes you get the chest pain if the tumor is involved more close to the lining of the outer lining near the chest wall. Then you get chest pain.
All right.
Sometimes you can cough up blood. That's a serious presentation. I mean, yeah, and you can get if it affects further away. So for example, if it's in the upper part of the chest, it can affect some nerves that can cause hoarseness of voice.
Oh, okay.
And it can also kind of compromise the center of the chest where you get shortness of breath.
All right. So when we talk about lung cancer, it just doesn't have to hurt where you think your lungs are located. It could be all the chest and a lot of symptoms.
Yes, I mean, so it is where if it's located, but if it's more in the center, you get these other symptoms where you have that difficult, the choking sensation. It all depends on where it is, the location of the tumor. And the other symptom, also weight loss, unexpected weight loss is another sign that you need to look for.
All right. So if a person is feeling any of these symptoms, where do they go first? What's the process?
Usually they end up going first to the primary doctor.
Okay.
And usually it starts out with an X-ray to see what's going on with the shortness of breath, what's causing the shortness of breath. And based on that, if they find a nodule, that's when the next step is the CAT scan. Computerized axial tomography, that's what it stands for. It's a more sophisticated X-ray which gives you more detail. And based on that, they can decide if it's amenable, depending on cancers that are central and in the periphery. As you know, the central lesions, you have to go with the bronchoscopy. The more peripheral lesions, they do a CT-guided biopsy. With the CAT scan, they put in a needle and get the biopsy.
All right.
And once they get the diagnosis, that's when we can get involved. So, and usually the local physicians call us up ahead and just say, hey, this is what's going on. And we sometimes guide them in what we need to do up front, so we don't waste time in that way.
Right.
And we can get the workup expedited, and by the time we see them, we know the stage, and we can start planning the treatment and appropriate referrals. Usually it deals with cardiothoracic surgeons.
Oh, really?
Yeah, usually it's a multidisciplinary approach. Basically, you want to get the cardiothoracic surgeon involved, an experienced cardiothoracic surgeon, a pathologist, radiologist, radiation oncologist. We all discuss this together, and we've got to get a plan going together, and what would be the right action to take.
You've been doing this for a while now, and do you have any memorable cases, anything that comes to mind that just sticks with you over the years?
Very, it's a happy ending case. Basically, that's the case I always tell everybody that asks me. So we had a 7-year-old gentleman that mid-70s, sorry, that had lung cancer. Not tolerating chemotherapy, and he was almost kind of giving up. He was ready to kind of sell his house, and kind of closing up the final chapter. It's kind of taking care of the things that he needed to do.
Right.
Then the immunotherapy came back. We didn't touch on that. That's another great innovation actually now that's changed the whole landscape of multiple cancers. But so we got him on immunotherapy, and his disease was even in the heart.
Oh my goodness.
Yes, and we started him on immunotherapy, and after 3-4 months, it started disappearing, and everything, even the nodules around the heart, everything disappeared. Now, I think he's about 2 to 3 years disease-free.
Oh, that's amazing.
Disease-free, still going on immunotherapy.
Totally changed his life.
Yeah, changed his life. He canceled selling the house.
Yeah, for sure.
So the immunotherapy has changed a lot in multiple cancers, including lung. Response rates are amazing. It's 30%, but people who respond for quite a long time.
Yeah, it sounds like it.
Yeah.
We have just a couple of minutes left here, but you said we didn't cover that. Can you explain what,
So what is immunotherapy? So we have a couple of immunotherapies. The one I want to focus is a PD1 inhibitors, so basically, and the PDL1 inhibitors, basically. So what is a PD1 inhibitor? So if you take interaction with the cancer cell and our T cells, our white cells, there's a protein on the cancer cell called the PD ligand, and there's the receptor on the our T cells, the white cells. So what happens is, as they interact, our T cells get more and more of the PD1 receptors. So more and more basically causes our cells to get exhausted. And so they're not able to do their job and fight the cancer. So what these inhibitors do is they block that effect. And thereby they don't upregulate the PD1 receptors, but they're more actively involved in fighting the cancer. So basically, your own immune system fights the cancer.
Wow, that's totally amazing.
Amazing. And the side effect profile is, it's not zero, meaning there is side effects related to it, but usually they're pretty well tolerated. And the side effects are related to your own immune system fighting your own body. So it can affect your lung, you can get shortness of breath, it can affect your colon, you can get diarrhea, you can get a rash, so it can affect anywhere. And usually you treat it with steroids.
Okay.
That's how you kind of dampen your immune response, so it takes care of the side effects.
Yeah, but we have heard this one success story. It can really make a big difference in a person's life.
And it has many in our cancer center. So
that's wonderful.
And throughout the nation too. And you'll probably hear a lot of these if you go out on the web, you'll see a lot of success stories regarding this.
Yeah, well, that's wonderful news. I appreciate you being here with us today. We've covered a lot of information out there, so it's been my pleasure to learn about this.
Thank you.
So thank you.
Thank you for having me.
Yeah. And thank you so much for watching this episode of Being Well, discussing the topic of lung cancer with Dr. Jagarlamudi with Sarah Bush Lincoln. And so if you need more information about Being Well, please visit our website at weiu.net and click on Being Well. We'll see you next time.
Sarah Bush Lincoln Health System, supporting healthy lifestyles, eating a heart-healthy diet, staying active, managing stress, and regular checkups are ways of reducing your health risks. Proper health is important to all at Sarah Bush Lincoln Health System.
Meeting the ever-changing healthcare needs of our communities, Paris Community Hospital Family Medical Center is now Horizon Health, with the same ownership, management, providers, and employees. Horizon Health provides patient care and promotes wellness to the communities of East Central Illinois.
At HS St. Anthony's Memorial Hospital, we are at work transforming heart care, rebuilding knees and hips, delivering new generations, and focused on providing health care to you. We are HS St. Anthony's Memorial Hospital.
Carle combines clinical care, health insurance, and research in a way that solves problems today with an eye toward the future. Supported by a deep philanthropic spirit and dedicated to making life better for as many as possible.